Dr. Giri Prasad.
Sir, good evening, sir.
Good evening. Dr. Kishwant and Dr. Subbaya are there. Hello.
Sir?
Dr. Giri Prasad.
Sir,
yeah, Dr. Kishwant and Dr. Subbaya are there to start the presentation. Who is going to moderate this session today? Kishwant is there. Or Dr. Subbaya sir is there? Dr. Subbaya, hematologist, are you there, sir? Dr. Giri Prashant, are we expecting Dr. Subbaya to join or not? Hello?
Sir?
Are we expecting Dr. Subbaya sir to join or not?
Sir, don't know, sir.
Don't know, but you are the presenter today. You're not aware about the faculties to join or not. And Ramachandran sir called me that he is not joining. Dr. Kishman, the AP of medical gastroenterology is there. I don't know whether Subbaya is there or not. His name is not displayed. So I'm not sure about his participation now.
Start now.
Otherwise, can I ask Dr. Kishwan, can we start the presentation, sir?
Yes, sir. We can proceed, I think, sir.
We can. Okay, then.
Yeah,
Just
sir.
because the name is there, Subbaya name is there, I'm not sure about his name is not displayed in the participants. Anyhow, we'll start the presentation, let him join later. Dr. Rameshwar is not going to join. He's in Gujarat now. He said he's not in a position to join. He's in a meeting there.
Yeah.
Okay, anyhow, I'll just introduce and start the program, and then Dr. Kishwant and Dr. Krish Prashant take over the further proceedings. Good evening and welcome you all for this evening. This API-ICP postgraduate virtual training program. This week we have the faculties from Department of Medical Gastroenterology, KAPV Trichy Hospital. We have with us Dr. Kishwant, this is Assistant Professor in the Department of Medical Gastroenterology. Really thank you, sir, for joining us today and being the faculty for this today's program. And we have with us Dr. Giri Prashant, the postgraduate from the Department of Medicine, KAPV Trichy, is going to present a case on abdomen system. And we are not expected at Ramachandran sir, the usual faculty is not expected because he's not in station now. And if Subbaya sir is going to expect to join, is most welcome. He's a clinical hematologist and BMT physician from Kaveri Hospital, Trichy. Hopefully he's going to join later. And I request Dr. Kishwant, the AP from Medical Gastroenterology, take over the further proceedings, requesting Giri Prashant, the postgraduate, to present the case. Thank you.
Thank you, sir. Thank you.
Good evening, sir.
Yes, this is Giri Prasad. You can start, I think.
Okay, sir. A 70-year-old male, Mr. Selvaraj, who is a farmer by occupation, resident from Lalgudi, came with his chief complaints of abdominal pain for 1 month, the abdominal swelling in the left side of the abdomen for past 10 days, history of presenting illness. The patient was apparently normal 1 month back. Then he developed abdominal pain in the left upper quadrant. Inside is an onset, progressive in nature, non-radiating, not increase on deep inspiration, often relieved with rest. He noticed abdominal distension for 10 days. Inside is onset, gradually progressive, extending up to umbilicus, not reduced on lying down, not non-pulsatile. History of fatigability for 15 days. History of loss of appetite for 15 days. History of early satiety for 5 days. No history of weight loss. No history of fever. No history of altered bowel habits, nausea or vomiting. No history of bleeding diastasis. No history of bleeding gums or petechiae purpura. No history of yellow discoloration of eyes, high colored urine or pruritus. No history of blurring of vision, breathlessness, pruritus. No history of bone pain. Past history. No history of similar episodes in the past. No history of recent surgery. No history of blood transfusion or tattooing. No known, not a known TB, diabetes mellitus, hypertensive, hypothyroidism, and seizures. Personal history: consumes mixed diet, alcoholic for more than 30 years, 1 quarter per week, discontinued 2 months ago, not a smoker, sleep pattern is normal, beaten at chewing for 30 years, discontinued 2 months back. Family history: no similar illness in the family members, no contact with TB patients. Summary: a elderly male who is a farmer by occupation with no known comorbids, who is a chronic alcoholic and beaten at sugar, presented with chief complaints of abdominal pain for 1 month, and abdominal distension for 10 days. From the history, the most probable system involved gastrointestinal system.
Okay. Can you wait, Giri Prasad? Can you go to the first
No.
slide?
Yes, sir.
Okay. In the presenting history of presenting illness, you have told the first complaint as abdominal pain and the second complaint as abdominal distension, right?
Yes, yes, sir.
But in the chief complaints, you have written abdominal swelling. What is the difference? What is the difference between abdominal swelling and abdominal distension? Why there is a change in presenting illness and chief complaint?
Abdominal swelling.
Yeah, what is the difference between swelling and distension?
Swelling is a localized collection or something.
Okay. Okay.
Distance
Then what is this?
generalized
So did the patient have swelling or distension?
swelling. Sir.
Swelling. Go to the second slide then.
Yes, sir.
Read the first line.
Abdominal distension.
Why is there is contradiction between your statements? Follow either one. Okay. If the patient says he had swelling, you can describe it as a swelling. He had described it as abdominal distension. Just describe it as abdominal distension itself.
Okay, sir.
Don't keep changing terms here and there. Okay.
Okay, sir.
Okay. I hope you had certain diseases in mind when you were ruling out or when you were pointing out the negative histories.
Yes, sir.
Right? You are able to rule out certain conditions for each negative history, right?
Yes, sir.
Okay. Why is there fatigability for this patient? Why did okay? He had fatigability. Fine. Go to the next slide.
Yes, sir.
Okay. Why did you ask for weight loss in this patient?
The patient's age is 70 years, sir. So in
Okay.
case of malignancy, we can expect a weight loss.
Okay. So far, you don't know what's
Patient.
the cause for abdominal distension, right?
Yes, sir.
Till this point, you're not sure what abdominal distension it is.
Yes, sir.
Could it have been ascites?
But generalized distension patient.
Yeah, that's what ascites is going to have generalized distension.
Yes.
So, do you expect a weight loss in ascites or weight gain?
Weight gain.
Okay. So before this slide, at the end of second slide, what was in your
Yes, sir.
mind? What disease was in your mind?
Maybe chronic liver disease.
Okay,
Maybe.
chronic liver disease. As far as the history is concerned, it looks like chronic liver disease.
Yes, sir.
Up to second slide. Okay. Then why did you have a suspicion of malignancy suddenly and you ask for weight loss in the first itself? Do you understand my question?
Yes, sir. Yes, sir.
No, you had till the history of early satiety, loss of appetite, fatigability, you had chronic liver disease in your mind.
Yes,
So
sir.
the next question should be history of jaundice or
Yes, sir.
altered sensorium. Why did you suddenly jump onto malignancy now in the next line? The next slide. And you wanted to rule out weight loss and malignancy. Any specific reason?
Yes.
Okay, better to put all these weight loss and appetite loss at the end, not at the
Okay.
beginning itself. Don't
Okay.
begin unless the confirmed case of malignancy that if the chief complaints are directly pointing towards malignancy,
Yes,
don't
sir.
ask for weight loss at the beginning or
Okay.
don't mention it. You can ask it, don't mention it in history like that. You can put
Okay.
weight loss and appetite loss at the end.
Okay.
Okay, why did you think of fever?
In case of malaria,
Malaria, abdominal pain, will the patient develop present with fever or will the patient present with abdominal pain?
yes,
Why do you think of malaria now? Don't keep splenomegaly in your head. You are just in
okay.
history. Patient has
Okay.
abdominal pain, abdominal distension. That's all. No other
Okay.
diagnosis so far.
Yes, sir.
So your questions or negative histories should be pointing towards the or try to rule out the primary condition from the chief complaints.
Okay.
You should not be ruling out the diagnosis.
Okay.
This history looks like you already know it's splenomegaly and you're ruling out certain conditions. The order of negative history you have asked or you are presenting now, it is like ruling out the causes for splenomegaly or ruling in the causes for splenomegaly.
Ruling out.
No, man. The way you have asked, the presenting the history is looking
Okay.
like you already know the diagnosis and you're trying to come to a conclusion that this is the diagnosis. Your history is not pertaining to the primary complaints. The way you are presenting.
Yes, sir.
So this should not be in this order.
Okay, sir.
Okay. What do you mean by altered bowel habits?
Constipation, diarrhea.
Constipation is constipation, diarrhea is diarrhea. What is altered bowel habits?
Sudden constipation. I mean, patient was previously normal இருப்பாங்க சார் சடனா ஐ மீன் ஒரு டெஸ்ட்ல
No, the
பேஷண்ட் வந்து
altered bowel habits, according to the literature, is a change between constipation and diarrhea, alternating constipation and diarrhea, not just isolated constipation and not just isolated diarrhea.
yes sir.
If they are isolated events, they are isolated events. It's diarrhea or constipation, not altered bowel habits.
Okay.
Person having altered bowel habits should be having alternating constipation and diarrhea.
Yes sir.
It points towards malignancy mostly, bowel obstruction or malignancy.
Okay.
Okay. No history of bleeding diathesis. The diathesis. Why suddenly bleeding diathesis? What were you trying to rule out?
It's also in case of malignancy, chronic liver disease.
Why, man, 15 days abdominal pain, abdominal distension? Why do you want to keep on beating around malignancy? Can't it be a benign condition? It can be an acute pancreatitis, the pseudocyst
It's a
formation or a fluid collection.
possibility of that.
Yeah, that's what you should go from common to uncommon. Why do you want to jump to malignancy? Why are you ruling out malignancies from the first?
Correct.
Your way of history should be ruling out things from the chief complaints from benign to malignant.
Okay.
You from the start, you know the diagnosis and you are coming to a conclusion. That is how your history presentation is. You should change this.
Okay.
Okay, why bleeding gums, petechiae, and purpura in this case? Abdominal distension. What is the relevance? Pain and abdominal distension for a short duration. What is the relevance between bleeding gums, petechiae, and purpura in this case?
Hematological. Sorry, sir. Hematological causes.
Why are you thinking of hematological causes now, suddenly? Which common hematological cause will lead to bleeding gums, will lead to abdominal pain and abdominal distension, or will present as abdominal pain and distension?
No.
I mean, I'm asking for common hematological conditions.
Hodgkin's.
How many Hodgkins have you seen? Or in other words, what is the common cause for abdominal pain and abdominal distension? You think of any case with abdominal pain and distension, you think of hematological conditions first? Or
No,
do you
sir.
even want to rule it out now with this history? Dr. Giri Prasad?
Eric.
Why
Sir.
the case of abdominal pain and distension? Are you getting my point? It's a case of abdominal
Yes,
pain
yes,
and
sir.
distension. Why did
Okay.
hematological cause come in between?
History of 1 month complaints, sir.
Okay. 1 month abdominal pain can be cholecystitis, acid peptic disease, pancreatitis. There are so many other common causes.
The severity milder, sir. So,
Sorry?
the pain severity was very mild, sir.
Okay. Why can't APD present with mild symptoms? Sorry, fine.
Okay, sir.
Okay. Why blurring of vision, breathlessness, syncope, and pruritus? Why are these clubbed together? Yellowish discoloration of eyes, jaundice, high colored urine, pruritus. Okay. Cholestasis and hepatocellular ruled out. Why blurring of vision, breathlessness, syncope, and pruritus?
This is also to rule malignancy, sir. Hyperviscous symptoms, sir. Okay.
And you already know the diagnosis and you are trying to fit in everything. That is how it is. Okay. Suddenly bone for abdominal pain and distension. I don't know why you ask for bone pain. Okay. Next slide. No history of similar episode in the past.
Yes, sir.
You want to rule out malignancy. How many times will the patient present with malignancy? Why do you say, okay, similar episodes means you want to rule out abdominal pain or abdominal distension in the past.
Yes, sir.
Okay, why recent surgery? What is the relevance? Okay, let it be malignancy itself. Why recent surgery?
Previous surgeries, surgeries related to spleen, maybe.
Why do you want to stick around spleen, man? That is my question. I just keep on asking you that only. How did you know it's spleen? With the history itself. Are you able to understand my question?
Yes, sir. Yes, sir. I'm able to
How
understand.
do you know it's spleen?
Yeah, Dr. Giri Prashant, are you understanding Sir's point? Because you're completely biased towards your history. That's what Sir is trying to reach you. Never do that mistake hereafter. Understand?
Okay, sir.
Yeah.
can
because
change the,
your points are all, everything is already made your diagnosis. You're trying to create your story and making the points of history nature you're presenting. That is easily picked up by any faculties. So don't try to do that. Be open mind, try to present and make the points what you feel like, then you'll start discussing.
Okay.
That's what sir is keep on trying to reach at you. Okay.
Okay.
Dr.
Okay.
Kishwan, please proceed.
Yes, sir. Nothing to worry. You are just in learning phase. We are just
Okay.
trying to help you. Okay. Don't do this.
Okay.
Don't keep the diagnosis in your mind and then ask history relevant to it. You have to rule out systems and you have to rule out the diagnosis and arrive at some point as some clinical condition. That's all.
Okay.
Okay. You can proceed with examination.
Sir, good evening, sir.
Sir, sir,
Raja Mahendran, sir. Yes, sir.
good evening, sir.
Good evening, Dr. Rajamagendran.
Yes, sir.
Welcome.
Yes, sir.
Yes, sir.
Uh,
Please.
Yes, sir. Giri,
Sir, good evening, sir.
good evening, Pa. So, hope you understood our both professors' inputs, Pa. So, you
Yes, sir.
no need to jump into conclusions. Just you are taking case as a case of splenomegaly for evaluation. That's the way you are starting presenting since the first slide, right? So, better avoid it. So, for discussion's sake, if at all this 70-year-old farmer presented with 1 month since of 10 days. So, tell me some differential diagnosis.
One month.
This is the history, no? This is the patient's history. So, from the history, what are the diagnosis comes to your mind in order of priority? Don't say splenomegaly, please.
Okay.
Yeah, tell me.
Patient is known alcoholic, sir, for
Okay.
more than 30 years. Sir.
Okay.
Chronic liver disease may be possible.
So, what is the definition time window to say chronic liver disease? In routinely, in chronic means more than 6 months duration should be there, right?
Yes, sir.
So that's the time window we used to keep to differentiate between acute or chronic. Okay.
Yes,
so have you mentioned about that alcohol dose, how long the patient is being taken or not, whether it's fit into cirrhotic dosage? Have you mentioned in the slide? Huh?
1 quarter per.
Try to mention in grams always, right? So don't jump into conclusion in this case of hematological malignancy. This may be a case of still a possibility. So from the history, you can't rule out decompensated liver disease. Still a possibility. So the patient is a chronic alcoholic taking cirrhotic dosage for almost 30+ years. So even though it's a spleen might be there in your examination, but still it's a case of chronic liver disease should be kept in your differential diagnosis, right?
Okay.
So tell me, what are the causes of abdominal pain? Medical causes of abdominal pain?
DKA.
DKA for 1 month, 1 month abdominal pain, 1 month or 10 days. How long the patient is having abdominal pain?
1 month, sir.
1 month, yeah, 1 month. 1 month abdominal pain. Yeah, tell me the causes. Okay, what are the things come to your mind? Yes.
Known alcoholic, sir. So pancreatitis.
Yes, definitely. You need to consider that all the inflammatory diseases like hepatitis or the liver enlargement or perihepatitis or spleen enlargement or peritonitis or pancreatitis. It needs to be considered, right? So, what is abdominal angina? Have you ever heard the term abdominal angina?
No.
So, it's a chronic mesenteric ischemia. What will happen to normal anginal pain, chest pain?
Aggravated by during exertion of
Okay. So in abdominal angina means mesenteric ischemia. So in chronic mesenteric ischemia, the patient will feel abdominal pain only after taking food. So typical picture will be the pain. The patient will start feeling pain half an hour after having his food. So the patient will be having fear of taking food. So usually associated with the weight loss kind of. So it's called as abdominal angina. So you need to discuss in detail about the abdominal pain. What sort of pain? What are the aggravating factors? What are the relieving factors like that? So you have mentioned as the abdominal pain relieved by taking rest. Why this patient abdominal pain relieved by taking rest? Could you explain? That was mentioned in your slide, right?
Yes, sir.
Yes. So if at all, what would be the cause for abdominal pain in this patient? You mentioned as the dragging pain kind of something. Okay, even though it's splenomegaly causing pain, okay, accepted. So how the patient taking rest, splenomegaly related pain is obsoleted? How is it possible? So probably maybe the movement producing stretching of all these ligaments, that gastrosplenic or renal ligaments, so that the stretching will be minimized during that rest period. So that may be the reason for that abolition of pain. That may be the explanation you can give. Okay. So if at all the patient is presented with pain with the distension, means you need to think of the same fluid. So what are the causes of fluid inside the abdomen? So what are the organomegaly causes with pain and organomegaly? So is it having any subacute intestinal obstruction? Is it possible to have subacute intestinal obstruction in this patient? 1 month pain and distension?
Yes, sir.
Okay, then how the pain in subacute intestinal obstruction and pain in this your case, organomegaly case?
Dragging pain.
Okay, in organomegaly means the patient will be having dragging pain. Yeah, it's a okay. In intestinal obstruction means the patient will be having colicky kind of pain. Yes. So have you asked the history of any encephalopathy, decompensated liver disease, portal hypertension? This splenomegaly might be one of the decompensated features. We don't know.
Yes.
So examination alone will give you a proper picture. So still we are in a history. So DCLD should be kept in your one of the different diagnoses. Have you asked about hepatic encephalopathy related features?
Yes, sir. But
have you mentioned? Okay. Then if you mentioned means no problem. Then any relevance to travel history?
But patient had no recent travel to endemic area.
Which endemic area you are thinking in terms of for which disease?
Malaria.
No, malaria, Tamil Nadu is also no endemic area, man. So Kala Azar. So Kala Azar still happens in some parts of the in northern India. So like what are the states associated with the Kala Azar? Yes. So yes, northern peoples are working left and right in our state. So if you come across any patients like this, all this history coming from this endemic area of Kala Azar, you have to keep it in your mind as a different diagnosis of Kala Azar also. So for that, you need to ask the travel history, right? Okay. Good. Then you mentioned as betel nut chewer, right?
Yes, sir.
What are the contents of betel nut and what are the ill effects of betel nut? Why did you ask specifically about betel nut chewing is in your history? So while eliciting this history, you need to specifically ask about whether the patient is having only betel leaves or associated with areca nut. Areca nut, the colloquially we are using the term betel nut. Both are different, right? Betel leaves plus areca nut plus that lime, that sunambu you used to say sunambu. Plus some patients also taken with the tobacco. So this tobacco, the areca nut, these are all the culprits, not betel leaves. Betel leaves are not much carcinogenic, I suppose. So maybe gastroenterologist might give you a clear picture. As far as I know, the betel leaves are not carcinogenic. This areca nut might have some fibrotic effect, so oral submucosal fibrosis might be developing in later part. But tobacco and that lime are inducing carcinogen. So you need to ask specifically about whether the patient taking this quid with lime, with tobacco, with leaves, what exactly you need to mention, right? Not simply saying betel nut chewer, not like that. Okay. Okay. Keep going. Okay. So from the history, you need to say some differential diagnosis. So from the history, you are saying first diagnosis is first differential diagnosis.
Chronic liver disease.
Yeah, don't say the patient is having gastrointestinal system patient. The patient himself is saying I'm having some problem in my gastrointestinal tract. So you don't say. So say some diagnosis, 1 or 2 diagnoses. From the history, all these past history, treatment history, everything you have asked. So after the end of history taking, say some different diagnosis. We will proceed with the examination. No problem. Say 1, 2, 3 something. Could you?
Patient non-alcoholic for more than 30 years. Chronic liver disease.
Okay, CLD is your first diagnosis. Okay, second.
Patient complex swelling, distance from the left side of the abdomen.
Yeah, everything I know. Just say the diagnosis, bullet points.
So,
second.
Old age malignancy may be possible. Stage of pancreas, malignancy related to.
Malignancy means which
organ? Tail of pancreas malignancy. Omental mass.
Okay. Pancreas malignancy is a second diagnosis. Okay. Okay, man. You're going somewhere. Okay. Giri. Good. Proceed.
Examination.
Yes. You can very well. Okay.
General examination. Patient was conscious, oriented to time, place, person, built-in nourishment adequate, pallor plus, no icterus, no cyanosis, no clubbing, no pedal edema, no generalized lymphadenopathy, no petechia purpura, no sternal tenderness, no fullness in the left supraclavicular fossa, oral candidiasis plus, no. Vitals, pulsate 70 per minute, regular rhythm, normal volume, no vessel wall thickening, no radiofemoral delay, BP 120/70 millimeter mercury right upper arm, respiratory rate 16 per minute, regular abdominal thoracic, SpO2 98% in room air, temperature 98.6 JVP not elevated.
1 minute, Giri. Before going in for examination of abdomen, go to general examination. Yes. Okay, good. So sternal tenderness. So how to make a sternal tenderness part? Because for anybody, if you are making some pressure over the sternum, the patient will wince with pain, right? So it's a normal procedure in your intensive emergency ward. Anybody unconscious, you will make some sternal pressure, the patient will wince with pain. That's the severity of pain assessment, right? So yes. So in what way differ from sternal tenderness on your case? Why did you elicit the sternal tenderness? Giri?
Patients.
Yes.
Okay.
Yes. Yeah, if at all, okay, I will change my question. If at all sternal tenderness is there, so what is your conclusion?
Leukemia.
Okay. So what is the reason behind this sternal tenderness in leukemia? So I'm coming to your point. If at all is a leukemia, okay, what is the reason for sternal tenderness in leukemia?
Bone marrow infiltration by malignant cells. This increases the pressure inside the sternum.
Okay, why specifically sternum? Why not you apply the same pressure over all other bones? There are so many bones in our body, no? Why specifically sternum?
It's a flat bone.
Yes. So it's a superficial bone. So it's easily accessible. Superficial bone, flat bone. So it's red marrow will be there. So even in adulthood, still hematopoiesis is actively happening only in flat bones, just like sternum. So any proliferation of any lineage, whatever happening, so it's happening in flat bones especially, rather than that other bones. So if even you are applying pressure minimally over the sternum, the patient will wince with pain. So how to differentiate the pain normally from sternal tenderness due to your hematological malignancy means even on just a simple thumb pressure alone will give the pain, severe pain, and deep-seated pain. The pain will be prolonged duration. But in case of normal patient without any hematopoiesis and without any intramedullary pressure increased patient, normally in our ward setup, if you apply deeper stimulus, the patient will begin with pain. So that will create a visceral pain. This is a periosteal pain, and intramedullary pressure is increased. So this is the difference between sternal tenderness in your case, whatever that actively myeloproliferative disorders or other normal patients, right?
Okay.
Okay. Then why specifically left supraclavicular fossa? Why not you look for right supraclavicular? If at all right supraclavicular node enlarged, does it mean it's a benign one or insignificant one? Is it so?
Maybe lung pathology, due to lung pathology, like supraclavicular node enlargement.
So even in the upper part of the esophagus drains into right supraclavicular. So still, so you need to look for both supraclavicular. But left supraclavicular means it's a pelvis and all other major intra-abdominal organs are drained into that area. So left supraclavicular Virchow's node is significant towards the abdominal and pelvic malignancy. But right supraclavicular, you need to look for. So if you are going for lymphadenopathy means you need to look for both right and left supraclavicular. No specifically for left supraclavicular alone, right?
Okay.
Okay, man. Okay. Next slide. Okay. It keeps on. Okay. No lymphadenopathy, no sternal tenderness. Okay. Next slide. So this patient, clinically, I mean, from clinically, you say in general examination, the patient is anemic as per your statement, right? So the patient is also having fatigue. So still the pulse rate is 70. So is it possible? Anemia with fatigability is there, still pulse rate is 70.
Patient chronic anemia.
Yes. Maybe compensated. Yes, chronic anemia. Good. Okay, man. Okay, great. So what about the signs of liver cell failure? You need to think of, no? So you need to mention in the general examination, signs of liver cell failure. That's the most important differential diagnosis as per your statement from the history. CLD is your first and foremost differential diagnosis from the history.
Okay.
But you're not looking for any clues for getting the diagnosis. So our Kiswan sir is right because you are making a case of splenomegaly, a case presentation like that. You have made a title. So not a Mr. X presented with this kind of symptoms. You are not going in that proper pathway. So better avoid. Okay. Okay, man. Okay.
Examination of abdomen. Inspection. Scaphoid abdomen. All quadrants moves equally with respiration. Fullness noted in the left upper quadrant and left lumbar region. Flanks free. Umbilicus appears to be shifted downwards and towards the right side, inverted and flushed with the surface. No umbilical hernia. No visible pulsations or peristalsis. No dilated veins. No divarication of recti. No discoloration of skin. External genitalia. Normal pubic hair distribution. Testis normal. Hernial orifices free.
Giri?
Sir?
Giri?
Sir?
The first statement itself is contradictory. It's a case of abdominal distension. You are telling it's a scaphoid abdomen. Distension cannot be scaphoid, right?
Yes, sir.
Scaphoid is devoid of any distension.
Giri, what is the normal shape of abdomen?
Scaphoid.
Scaphoid in cachectic conditions. So it's usually mentioned as neither scaphoid nor full. It's a flat. So usually
flat abdomen.
Yeah, yes, sir, correct, sir. Yes, sir, super. So it's usually say abdomen is flat. That is the normal one. So it's neither scaphoid nor full, right? So if your full means it's abnormal, it's scaphoid also it's abnormal. So how many of us are having scaphoid abdomen? So it's only in cachectic conditions. So it's obviously contradicting. Scaphoid abdomen with the fullness. So better avoid the first line. So you can very well start with the second line itself. So abdominal fullness noted in the left upper quadrant. That's a nice statement, right? Okay. Then why did you mention about specifically about normal pubic hair distribution? What do you mean by abnormal pubic hair distribution, normal pubic hair? Avoid all these unnecessary wordings. If you are having anything in mind, just let me know. Otherwise, better avoid all this. Okay. Okay, man. Proceed.
Next. Palpation. Measurements. Abdomen width 75 centimeter. Distance from episternum to umbilicus 18 centimeter. Distance from umbilicus to pubis 17 centimeter. Umbilicus to anterior iliac spine on right side 16 centimeter. Umbilicus to anterior spine on left side 18 centimeter. On superficial palpation, no warmth, no tenderness. On deep palpation, non-tender, firm structure with the sharp border belt extending from left hypochondrium about 16 centimeters from the left costal margin, extends diagonally towards the umbilicus and does not cross the umbilicus, moves with the respiration, not able to insert fingers under costal margin, not palatable, probably spleen with the Hackett grading force. Other findings, liver not palpable, renal angle free. Percussion, upper border of liver corresponds to 5th intercostal space. Liver span at mid-clavicular line is 12 centimeter. Trough space percussion not obliterated. Castell's method, dullness noted on both inspiration and expiration. Nixon's method, dullness extends more than 8 centimeters from the left costal margin. Auscultation, bowel sounds present, no venous cum, bruit or rub. Rectal examination, normal sphincter tone, fecal stains present, no blood stain. Other system examination, CVS SNS2 present, or bilateral air entry present. CNS, no focal neurological deficit. Provincial diagnosis. A case of massive splenomegaly with no evidence of portal hypertension. Sir?
Giri, can you go to the previous slide? Previous one. Even before that. So the description of your swelling, right?
Yes,
will spleen have sharp borders? Spleen will have rounded borders.
okay.
Only liver, when enlarged due to certain conditions, will have sharp borders.
Yes, sir.
And Hackett grading 3, I think. It's not 4. 4 is crossing the umbilicus.
Yes, sir.
You have written 4. 4 is crossing the umbilicus and 5 is reaching the right pelvis. Right side of the, I mean, right iliac fossa.
Yes, sir. It's
okay.
3.
Kindly change it on the next slide. Drop space, Castell's method and Nixon method all are used for mild splenomegaly to detect whether spleen is enlarged or not. I think it's a case of small massive splenomegaly. You don't have to mention it.
Okay.
Okay. Then the diagnosis. Splenomegaly itself is a sign of portal hypertension.
Yes, sir.
And how can you tell it's massive splenomegaly with no portal hypertension?
Other decompensated.
No, portal hypertension is different from decompensation. Portal hypertension is different from decompensation. Portal hypertension can occur even without liver disease.
Yes, sir.
There are certain conditions called extrahepatic portal venous obstruction, non-cirrhotic portal fibrosis,
yes,
sinistral portal hypertension. All these will have splenomegaly without liver disease.
Okay.
the diagnosis itself is contradictory again. Massive splenomegaly without any portal hypertension. Splenomegaly is a part of portal hypertension clinical signs.
Yes, sir.
Okay, I don't think it is right.
Okay, sir.
It can tell it's a case of massive splenomegaly.
Okay.
But still, it's not massive. It didn't cross the midline, right? It's moderate. Packet 3 is moderate.
Okay.
Okay. Go on.
Agree?
Okay.
Sir, in the palpation, you mentioned
Sir?
about everything about spleen, but have you looked for any bruit, splenic bruit? This much of splenomegaly, you need to look for bruit. Okay.
Okay.
You need to mention that. Okay. Then, as Sir said, this sort of splenomegaly, this is easily palpable spleen. No need to look for all other methods and put the patient in left lateral, right lateral. No need for, right? Even the supine position,
Okay.
the patient the spleen is very well palpable.
Okay, sir.
Okay. Then in other system examination, what is the importance of all other systems? In case of case of splenomegaly, then why do you want to check CVS, RS, CNS in this patient? What do you look for in CVS? Why do you want to look for CVS?
Yeah. Anemia, basically easy fatigability complaints, sir. So anemia, high output murmurs.
Anemia related cardiovascular system effects. Okay. Then any other cardiovascular condition you presented with the splenomegaly? So
Infective endocarditis.
Yes. You need to say that. Okay. Infective endocarditis is one of them. It's a cardiovascular means it's a congestive splenomegaly might be there. So you need to look for congestive heart failure related findings. Then your patient is having anemia, so you need to look for anemia related CVS findings. And one of the cause for splenomegaly related cardiovascular system is infected endocarditis. So subacute infected endocarditis might be the cause for this mild to moderate splenomegaly. So you need to look for that. So peripheral signs and cardiovascular system. Okay. Then respiratory system, specifically non-KVAS checking the respiratory system is okay. You want to search for any findings, or are you in thinking in terms of any RS related splenomegaly? This patient.
Tuberculosis.
Yes, exactly. So yes. So disseminated tuberculosis. So this splenomegaly is a part and parcel of disseminated tuberculosis. So you need to look for other organ related tuberculosis, especially pulmonary tuberculosis and extrapulmonary like pleural effusion. So you need to look for that. Yes, good. Okay. In CNS, so it's one of the decompensated liver disease cycle. So you can check for hepatic encephalopathy and other. If at all is a malignancy means, so CNS metastasis you need to look for. Okay. Other immunocompression means infection also you need to look for. Okay. Okay. So what is your final diagnosis? Are you going to say diagnosis straightforward, or like to offer differential diagnosis from the history? This is the history. So examination we have concluded a final conclusion part. So what is your diagnosis? Yes.
It's a case of massive splenomegaly. So differential diagnosis.
Sir repeatedly selling, no, it's not crossing the umbilicus. Then why are you using the term massive?
Sorry.
Yes.
It's a case of moderate.
Okay, good.
Differential diagnosis. Chronic myeloid leukemia.
Okay.
Chronic lymphoid leukemia, myelofibrosis, hairy cell leukemia, lymphoma, infections like patients having oral candidiasis, so immunocompromised status like HIV, disseminated TB.
Okay. Are you going to start with 7, 8 diagnoses, or are you going to say a few more?
Oh,
Next slide.
see, mostly
Next slide. Okay,
investigates.
good. Okay, go for previous slide. Okay, so from the history and examination, so why are you saying CML, and what are the points favor for CML and what are the points against CML? So like that, you need to discuss all these 8 diagnoses. What are the points favor for this 8 diagnosis? What are the points against this 8 diagnosis?
The patient age is 70 years. Sir.
Okay.
So what common cause for splenomegaly old age numbers? CML.
Go on, Green. You might have studied well, no? Just
Easy fatigability compensatory, sir. So
okay.
So anemia is one of the features of malignancy.
So it's present in all the old age. CML fits into old age. CLL fits into old age. Myelofibrosis fits into old age. Hairy cell leukemia fits into old age. Lymphoma means some lymphomas might develop in old age, non-Hodgkin's. So infections disseminated with no age bar. So everything fits into age. So fatigability happens in all. So maybe due to different mechanisms. Some due to anemia, some due to cachexia, some due to other cytokine related problems. So everything fits into no. So
Yes.
yeah, how to delineate, how to differentiate. We need some points against all these. Then only we can narrow down.
Okay.
Ah.
Firm non-tenders.
Okay.
So malignancy possible.
Okay. So how the spleen will be in myelofibrosis? Will it be a firm spleen or hard spleen?
Firm.
Mostly it's a fibrotic spleen, no? It's associated with fibrosis. So most of the time it's a hard spleen, I think.
Okay.
Okay. Then CLL, how to differentiate? You need to say, just simply putting on slide means it will not solve the problem. No, you need to say what are the points against all this.
CLL mostly asymptomatic தான் சார் இருப்பாங்க.
Okay.
But the patient வந்து fatigability in the complaints இருக்கறனால அது one of the different diagnoses ஆ வச்சுக்கலாம்.
CLL patient will be having recurrent infection might be there. Recurrent infections is a hallmark of CLL. Maybe asymptomatic, but recurrent infection might be there. Okay. Associated lymph node enlargement might be there. This patient doesn't have any lymph node enlargement. So this point favors for CML. So in myelofibrosis, your case typically fits into myelofibrosis also. Only splenomegaly, moderate splenomegaly is there. No other age factor. Myelofibrosis typically fits into. But myelofibrosis usually associated with the pancytopenia related symptoms. So you're having anemia symptoms, but doesn't have any leukopenia, thrombocytopenia related symptoms. This patient doesn't have, right? As of now. So like that, like that you need to discuss. Okay.
Early patient having early satiety, dragging type of pain. So these points favor for CML.
Okay. Next.
Firm spleen.
Okay, what about dissemination? What about tropical splenomegaly syndrome? What about HIV? What about disseminated TB? You need to rule out everything, lymphomas, everything you need to rule out. The patient doesn't have any lymph node enlargement, so lymphoma is less likely. As of
oral patient oral candidiasis.
Okay.
So HIV may be another differential diagnosis.
From the oral candidiasis, you are going to say HIV. HIV, okay. Having this much of spleen in HIV, what would be the cause for this much of splenomegaly in HIV? திடீர்னு சைலண்ட் மோட்ல போயிடுற கிரி. Okay, proceed. Whatever you want to go say.
Sir, hello, Giri.
No, sir. Solid.
Okay, I'll give you one chance to add
Okay.
one more DD in neoplasm and one more DD in infection, non-neoplastic,
Okay, sir.
which is more common than all these hematological conditions. And patient is a chronic alcoholic. Anything, any malignancies pertaining to alcohol?
Hepatocellular.
Hepatocellular will be on the right side, right?
Okay, sir.
He's having splenomegaly.
Yes, sir.
Okay, pancreatic malignancies will cause portal vein thrombus.
Okay, sir.
Portal vein thrombus can develop splenomegaly, moderate splenomegaly,
Yes, sir.
which is more common than all your hematological malignancies combined together.
Okay, sir.
Okay, did you think of non-cirrhotic portal fibrosis?
But non-cirrhotic port fibrosis usually in young adults, second, third, or fourth decade, and that
That is
is most common.
That is EHPVO. Extrahepatic portal venous obstruction is different from non-cirrhotic portal fibrosis. Both have different mechanisms. Non-cirrhotic portal fibrosis usually occurs after middle age.
Yes, sir.
Okay. Okay, go on.
I'm Giri.
Sir.
From the history, so everything fits into all your neoplasms, everything. So, for example, but in lymphoma, the patient will be having mostly of B symptoms. They used to say.
Yes, sir.
What is that? What are the B symptoms?
Fever, night sweats, loss of fever, night sweats, loss of appetite.
So weight loss. So why it's called as B symptoms? So it happened in Annie Arbor staging system. So these three symptoms, if at all is present, this is a binary classification system. They classified as A and B. That's all. A means absence of symptoms. B means presence of symptoms. That's all. There's no big deal about it. That it's used to be Ann Arbor staging system for lymphomas. So we are using for lymphomas and non-Hodgkin's and Hodgkin's. So these B symptoms will be there in lymphoma. So from the history point of view, the patient doesn't have any B symptoms. So lymphomas are less likely from the history point. Right? Okay, wow. So I'm saying only about neoplasms. So from the general examination point of view, so lymph nodes will be predominant or prominent in CLL and lymphoma. So this patient doesn't have any lymph node enlargement from the clinical examination. So CLL and lymphomas are less likely. So sternal tenderness mostly present in CML and myelofibrosis mostly. So all these hairy cell lymphomas, CLL will not be having sternal tenderness.
Okay.
So then the thrombocytopenia related symptoms like petechia, that ECU bruises kind of things are possible only in hairy cell leukemias and myelofibrosis most of the times. So rather than on CML and CL. So like that you need to, you can say from the history, these are all the points favor for this, from the examination, these are all the points against that. Like that you need to say, okay. From the spleen also, I already told, no. So in CLL, this sort of massive spleen is very rare in CLL kind of. But moderate to massive spleens are possible in CML, myelofibrosis, hairy cell leukemia, even your tropical splenomegaly, that malarial splenomegaly, malarial spleen syndrome, there are possibles. So like that, you need to delineate everything. Okay. So portal hypertension should be kept in your one of the difference diagnosis. So definitely it will not be acceptable if you are not adding portal hypertension in your differential diagnosis. Maybe a cirrhotic or non-cirrhotic, whatever. But portal hypertension should be in your differential diagnosis. From the history, we can't clearly say you're adding tropical splenomegaly syndrome and all. But chronic alcoholic, you're still not considering portal hypertension, means it's better at least keep it as a last differential diagnosis. Better include. Okay.
Oh.
Okay, man. Okay, proceed.
Investigation. Complete blood count, liver function test, renal function test, peripheral smear, serum LDH, VCTC, CD4 count, viral markers, smear for malarial parasites, serum immunoglobulin levels, molecular testing, bone marrow examination, and fluorescent in situ hybridization.
Giri.
Sir.
Ultrasound inga. Sorry, sir. Splenomegaly and CML related evaluation fish. You are putting fish in your investigation chat, but should be in order, right? So
Okay.
even though clinically you can't able to say free fluid, but still if you are able to find out the free fluid in the by ultrasound, it will give you diagnostic yield. So it's altogether that we are going in for different path, right? So ultrasound or radio imaging techniques are most important. Even though it's clinically palpable, moderate to massive, I know that you are having super fingers, you are palpating so much findings, but still that radiological investigations does have a role. Okay. So you need to prove that portal hypertension, whatever, how to prove portal hypertension, all these and all missing, I think. All these investigations points towards your CML. You want to prove that CML and other related complications. You want to prove that patient is having tumor lysis syndrome or not, whatever. It's like that only you are putting investigations. Better avoid. Okay. So go one by one. So from the history, go for relevant examination findings, all the positive findings, put it in a different diagnosis, then go for investigations accordingly. So blood investigations, invasive, non-invasive, radiological investigations in order. Then go for confirm your diagnosis, then go for etiological investigations. Okay. Okay, Giri, proceed. Oh, that's all. Oh. Okay, in complete blood count, what will happen to your CBC in myelofibrosis, CBC in CML, CBC in other findings, other your different diagnosis?
Myelofibrosis, pancytopenia.
Yes. Okay. In myelofibrosis and Harris leukemia, mostly we having pancytopenia. Okay. In CML, in your that's your diagnosis, no? So CML
total more than 50,000, 1 lakh per particle.
CML more than okay. So you are saying CML as your primary first diagnosis, but how is it possible to have this much of spleen enlargement in a 1 month period? If at all the patient is in otherwise a blast crisis. So 1 month, this much of spleen enlargement, how you are going to explain? So if at all the patient is in blast crisis, it's explainable, but blast crisis without this much of symptoms, the patient is having only dull aching pain and all, no symptoms, no classical crisis symptoms at all. But 1 month duration, this much of spleen, how to explain, ma? So if you are going to say it's a chronic axillary, if at all it's a CML, it's a chronic phase only, no? So it's not in a crisis. Okay. How to say it's this?
Patient notice பண்ணது last 10 days தான் சார். But discomfort வந்து 1 month இருந்தது சார். இந்த swelling notice பண்ணது வந்து last 10 days தான் சார் அவர் நோட் பண்ணிருக்காரு.
Okay, you can give explanation like that. The patient's time history might be a bit delayed apprehension maybe. So patient might have noticed for the past 1 month only. The symptoms might have started a quite longer period. Okay, you can explain that. Okay.
Why does the patient has anemia? You told he had pallor, right?
Yes, sir.
So it indicates that patient is anemic. What is the reason?
Yes, sir. Please.
Okay, forget about malignancy. He's just having a splenomegaly due to some other cause. Massive, moderate to massive splenomegaly. If he's not
Okay.
having a malignancy, why is he having anemia?
Spleen.
In other terms, I'll ask you directly. What is hypersplenism?
Direct question. Hypersplenism.
This is X. Splenic destruction, அதாவது mature orbis is destruction
No, what is hypersplenism?
overactivity of the spleen, sir.
Overactivity. What will it do?
This will cause anemia, leukopenia, destructions.
That's not destruction,
Anemia.
it's sequestration.
Okay.
Any one or more cell lineages, if there is cytopenia, then it is called as hypersplenism.
Yes, sir.
It can be either anemia, it can be a bicytopenia, or it can be pancytopenia.
Yes, sir.
Most commonly, the commonest cell to have cytopenia is thrombocytes.
Okay.
There will be thrombocytopenia in a case of moderate to massive splenomegaly.
Okay.
If you do not find out a thrombocytopenia in a case of enlarged spleen, then it will be a malignancy.
Yes, sir.
It's a dictum.
Yes, sir. Okay.
For any case of splenomegaly, if you don't, in your investigations, if you don't have a thrombocytopenia, it will most probably be a malignancy, and this is how this case was diagnosed.
Okay.
This patient did not have thrombocytopenia with the massive spleen.
Yes.
Okay.
So at any moment of time, that almost 40% of platelets will be sequestrated inside the spleen. So this much of spleen occupying almost more than 50% of platelet might have sequestrated. So the obviously the patient will be presenting with thrombocytopenia. That's the explanation. So normally we are expecting that thrombocytopenia might be there, but with no thrombocytopenia means
Excess of platelets.
so it's it's one of the clues. As said, that's a classical clue. So hypersplenism you need to consider.
Okay.
Okay, Giri.
Okay.
Okay.
If at all it's not a malignancy,
Okay, sir.
you are planning for and consider this patient to have a young age. This is a totally different scenario.
Okay.
So this patient is a 30-year-old male or female who has
Yes,
a
sir.
massive spleen.
Okay.
When do you consider this patient for splenectomy, or do you consider this patient for splenectomy at all? With just abdominal pain and distension.
Hypersplenism features. There is no.
Okay, just not hypersplenism features. Complications due to hypersplenism features, if they are present, you can consider it for splenomegaly. If it is causing a mass effect, or if it develops some kind of abscess or infection, or it gets ruptured, these are the indications for splenectomy.
Okay.
And if there are more than 5 transfusions per year, if the patient requires more than 5 transfusions per year, then you can go for splenectomy.
Okay.
Okay, what are the prophylactic vaccines you would give for splenectomy, before splenectomy, and when will you give?
After splenectomy, Streptococcus pneumoniae, Neisseria meningitis. These infections are most common, sir.
Okay.
Encapsulated organisms.
Okay.
So
when do you give the vaccines? Before splenectomy or after splenectomy?
Before splenectomy.
How much before? Okay, it's before 2 weeks.
Okay.
You should plan for all the vaccine, completion of all the vaccines, especially pneumococcus, meningococcus, and Haemophilus influenza.
Okay.
These are the 3 vaccines which are mandatory to be given before splenectomy, at least 2 weeks, or at least before 1 week before splenectomy.
Okay.
Okay, fine. So from the beginning, you had only spleen in mind.
Giri. So,
Yes, Giri.
so even though it's a malignancy might be the most probable explanation for your case for this major splenomegaly, but you need to consider this reversible infective causes, and you need to rule out first, right? So hyperreactive malarial splenomegaly, that disseminated tuberculosis. So these and all should be diagnosed because these are all very much treatable and curable. So even though some hematological malignancies, including CML, are very much having excellent prognosis, but infective causes always should be your priority rather than labeling the patient as a case of hematological malignancy, myeloproliferative disorders, whatever, right? So always try to identify the treatable causes, even though that may be relatively rare compared to your provisional diagnosis. But you should not avoid that making a diagnosis. Okay. So portal hypertension, that infective causes. So these are all correctable, and if you need to correct the etiology, it will be definitely the patient will be having better prognosis and morbidity. Okay. Okay. Sir, hematologist, sir.
Hello, sir. I just joined.
Yes, sir. Good evening, sir. Good evening, sir. Yes, sir, please.
Sorry for the delay. I could not
Yes,
join. I just joined.
No issues, sir. No issues, sir. So shall I ask the PG to just summarize, sir, in a gist?
Sure.
Giri.
Sir.
Just summarize in a single slide. Summarize in the history and your final diagnosis in a single slide. Hematologist is on the line.
Okay, sir. Elderly male, farmer by occupation, no known comorbidities, was a chronic alcoholic, presented with the chief complaints of abdominal pain for 1 month, and abdominal distension for 10 days. Sir.
Okay.
On a general examination, patient is conscious, pallor plus, no generalized lymphadenopathy, no icterus cyanosis, oral candidiasis plus, no generalized lymphadenopathy. Vitals stable, sir. JVP not elevated. Examination of abdomen and inspection. Fullness noted in the left upper quadrant and left lumbar region, sir. Flank free, umbilicus shifted downwards and towards right side. All quadrants moves equally with respiration.
You mentioned
deep palpation.
distension and abdomen distension for some time, followed by pain, which is acute.
Abdomen pain first, abdomen distension, and then he noticed distension for 10 days.
So that is something important. If there are if you find an abdominal distension in the absence of any fluid collection,
yes,
what are the possibilities you will think? You're not making any fluid, but you're making a mass.
Yes.
Probably it's from an organomegaly or any mass presenting, but it's there been for some time, or based on whatever you have described in the history. On that background, if you notice, or if the patient complains of a new onset pain, what will you think? There's a distension. It's a mass that you're presuming it's a mass, and now he develops a pain. So
compressive effects.
Yeah, so some acute there's some sequelae which is happening to the mass. So that is bringing him to you. So maybe that might have been there for some time. So moment you find a mass which is not symptomatic in you, which is bringing the patient to you, you'll have to think about certain features. One is compression is something which you can think about. Then what else you would think of?
Vascular
so there's an imbalance between the metabolic activity of the lesion and blood supply. So that's something possible. So vascular compromise, insufficiency of arterial supply. That is something which you can think of. Then, so one is the vessels may not be obstructed. The demand might be poor, or else the vessels might be obstructed due to a compression, or maybe if undergoes like a torsion or something. If it's those are something which you should think of. And obviously, infarct, that's a sequelae. So that is more important. Usually, when you find a mass, the lesion is there for some time. It's unusual to find a mass, especially if there is no pain, and if you find a mass, it's almost always chronic. It's unusual to find an acute mass without pain. So usually, if there is no pain and the mass is there for some time, it's usually chronic.
Okay.
Okay, you go on. I just want to make out that that's why I stopped you in.
On depalpation, tender, non-tender, firm structure with a sharp border felt extending from left hypochondrium to about 16 centimeter from the left costal margin, extends diagonally towards umbilicus and does not cross the umbilicus. Moves with the respiration, not able to insinuate fingers under the costal margin, non-palatable, probably spleen. And percussion, trough space of Nixon's method does not extends more than 8 centimeters from the left costal margin. Other system examination is normal.
Okay.
The case of massive splenomegaly. Sorry.
Okay, so provisionally it's a massive splenomegaly and no evidence of portal hypertension, either on history or findings. Okay. So evaluation.
Differential diagnosis include is chronic myeloid leukemia, chronic lymphoid leukemia, myelofibrosis, hairy cell leukemia, lymphoma, infections like disseminated TB, HIV, tropical splenomegaly syndrome. These are all the possible differential diagnosis in states.
Okay. The patient is toxic with these findings. Massive spleen is toxic, running high grade temperature.
No, sir.
No. In case if you find a patient toxic with these symptoms, what all you'll think of amongst these possibilities? Which all will present? Where you'll find what are the scenarios where the patient will be sick looking?
Splenic abscess.
Yeah, so that's something. But usually you don't find such a large abscess. Usually they are multifocal. Unusual to find liquefied unifocal lesion there. It's very rare. But yes, possible. That's something possible. Splenic abscess. But the volume is usually not so high. Rarely you find that scenario. Okay. In these scenarios, the neoplasm, whatever you have listed. So what are the scenarios where you will see the patient will be in a toxic state?
Blast crisis.
So CML blast crisis, yes, that is something possible. It's very unusual. So most of the CMLs are incidentally picked up. 70-80% of the times you just accidentally pick up splenomegaly when you examine for some other problems or on a routine health checkup. That's most of the CMLs are incidentally picked up. Rarely they come with symptoms. And blast crisis is not, it's very rare at least a diagnosis. Maybe less than 5%, we would say 100 CMLs, less than 5% would, not even 5% would be in blast crisis. Okay, that's something possible then. CLL, will it be toxic? Very unusual. Usually you don't see. Myelofibrosis? Am I audible?
Yes, sir. Yes, sir. You are audible only, sir. Yes, sir.
I think we lost him.
Gilly, what happened? Giri? Yes, sir. He's not in the.
So myelofibrosis also
Yeah,
usually.
joint. Yes.
Hello.
Giri, unmute. Yeah, unmute and just answer.
Slides are not visible. Yeah, so myelofibrosis, will it be toxic?
No.
Usually not, but you'll have some all those annoying symptoms, non-specific abdominal distension, loss of weight. Fatigue is something very common in myelofibrosis, bone pains, back pain, those kind of things would be there. Hairy cell leukemia, usually not symptomatic.
Okay, sir.
Yes, you'll just pick up a splenomegaly when you evaluate, you'll have pancytopenia. Very unusual to see. It's something almost like CML, but you will have pancytopenia instead of leukocytosis or thrombocytosis. Lymphoma, low-grade lymphomas versus high-grade lymphomas. Where will you see a large spleen? So usually it's the other way around. Usually you see a large spleen in a low-grade lymphoma. The body has some time for all those cells to divide, proliferate. Slowly the splenic capsule expands and it takes time. High-grade lymphomas are rapidly growing, so you don't have much time. They present with symptoms before the mass forms well. So it's very rare to find a large spleen in high-grade lymphoma. They present with nodal mass, high-grade fever, weight loss, or sometimes you may not see weight loss. Chronic lymphomas, they have all the time. So slowly the spleen might enlarge, nodes might develop, and usually we see a large spleen in a low-grade lymphoma. Unusual to see in a high-grade lymphomas. So low-grade lymphomas will have large spleen. Nodes might be there at multiple stations, and all significant weight loss, and high LDH, but not very high to that level in an high-grade lymphoma. Marginally raised or minimally raised LDH, not like those in a high-grade lymphoma.
Okay.
Infections, you have listed those, TSS, disseminated TB, HIV. So, but we don't see often tropical splenomegaly and all. So obviously you'll have to consider. Though TB is more common, we'll have to look for the other features there. Okay, next slide.
Person dying. Investigation.
Yeah, so you have asked for a complete blood count, liver function test, renal function test, peripheral smear, serum LDH, viral markers, CD4 count in case if it turns out to be a retroviral disease, and malarial parasites and immunoglobulin levels. Anything else you could think of?
Ultrasound.
Okay, that anyway you have picked up a spleen clinically. So
bone marrow.
What are the other findings where your sonogram will help you apart from the splenomegaly? Whatever you have picked up. You know already there is a splenomegaly. So what more you expect in an ultrasound? It's already nicely palpable, large spleen.
Liver changes.
Yeah, one is to see for liver changes, whether it's causing the splenomegaly. That is something you have to see for. Then so you can also see for associated adenopathy, whether it's there or not. Any nodal involvement, that is something which you can see. And you were describing the pain which has brought the patient to you,
Yes, sir.
If he complains of pain, what will you look for in the ultrasound? He has a pain for 10 days, for 10 days,
Yes, sir.
and you're palpating the spleen.
Yes,
So
sir.
might be tender, may not be tender. Okay.
Yes, sir.
You didn't mention about anything about the tenderness. So he has come with pain, and in the ultrasound, what will you see for? If there's a splenomegaly, and then it's a spleen, he has got pain.
Yes, sir.
So you'll have to see for any splenic infarcts are there or not.
Okay, sir.
So that is something where you can pick up on the ultrasound. Obviously, splenic abscess, multifocal lesions, or unifocal, whether it's liquefied or not, size of the abscess and all, you can get from there.
Okay, sir.
Anything else you could think of? Compressive symptoms, any associated hydronephrosis, all those
Okay,
you have to see in the ultrasound.
okay, sir.
Okay. Any possibility of autoimmune disorder here?
No, sir. Patient age is 70 years, sir.
Okay, why not 70 years? If a direct Coombs test turns out to be positive?
Hemolysis, yes, sir.
Yeah. So in a young female, you would think of an autoimmune disorder causing SLE or an autoimmune disorder present, maybe an autoimmune hemolytic anemia. If you find the same picture in this scenario, an elderly male with a massive splenomegaly, and he has got some icterus on examination, and your findings are showing an indirect bilirubinemia, raised LDH, and your DCT turns out to be positive, then so this is something important you have to remember. Whenever you find an autoimmune hemolytic anemia in an elderly, always screen for lymphoma. It's most likely a low-grade lymphoma.
Okay, sir.
Either it could be a CLL or a follicular lymphoma or a marginal zone lymphoma. So that is something, it's an important takeaway point. If you find a hemolytic anemia or an immune cytopenia, an immune thrombocytopenia, especially with presence of hemolytic features, it will be presenting more like an Evans syndrome. You will have bicytopenia, maybe a macrocytic blood picture, raised bilirubin, indirect fraction, raised LDH. If you find a macrocytic anemia or an indirect bilirubinemia or raised LDH, especially with some splenomegaly, always ask for DCT. If direct Coombs test turns out to be positive, mostly you might be dealing with a low-grade lymphoma, which is presenting as a secondary autoimmune hemolytic anemia. So if you just pick up the autoimmune phenomena and treat with steroids, he'll transiently improve. If the lymphoma is not addressed, he'll relapse back, or he may not show a complete response. One other clue is retic count will be usually low in these scenarios.
Okay, sir.
But it's not always. Even with lymphomas, you might find a high retic count, and even without a lymphoma, you might find a low retic count. In general, if you find an autoimmune phenomena, rule out for an underlying lymphomatous pathology there. Autoimmune may be the target of the autoimmune process could be hematological system or could be other system also. It could be an autoimmune neuropathy or vasculitic-like phenomena. Whenever you find an autoimmune phenomena in an elderly, look for underlying immune neoplasm. So that is what it's like a lymphoma. Immune system transforming into a malignancy. So that is where the antigens all get misdirected, and the patient might be presenting with an autoimmune feature. So DCT is important here. Whenever you find an elderly with a lymphomatous process, then you have to ask for a direct Coombs test. And also, in patients with chronic lymphocytic leukemia, you will see a proportion of patients presenting with autoimmune hemolytic anemia. So marrow becomes mandatory here. So you have to do a bone marrow to rule out lymphomatous process. Why immunoglobulin levels?
In case of tropical splenomegaly syndromes,
IgG, raised IgG.
IgM may be elevated.
Okay, then where else immunoglobulins would be useful for you?
Multiple myeloma.
But myeloma, you don't see a large spleen. In case if you're suspecting a myelomatous plasma cell disorder and you find a large spleen, what will you think of? So there, it could be a Waldenstrom's macroglobulinemia. It again falls within that same family, plasma cell pathology, but it presents more often with an IgM heavy chain type. So usually it's had a high GM, though, and it's hyperviscous. You'll see a high total protein, and a low albumin. So that's what you see as AG reversal there. So organomegaly, adenopathy, and high immunoglobulin levels, especially IgM, then you have to think about Waldenstrom's macroglobulinemia there. And your flow cytometry would give you the clonality of those lymphomatous cells. Suppose this turns out to be a retroviral disease, the splenomegaly may be due to the viral pathology itself or some other infections associated with it. And even the retroviral disorders can have lymphomas associated with it. And there are some specific lymphomas like Burkitt's and all, it's well, DLBCL, they are well associated with retroviral disease. If it turns out to be a retroviral disease and you find a high protein, still there also it's possible. You see a polyclonal elevation there. It's usually not monoclonal unless you have a malignancy underlying that. There also you see a high total protein would be high in that scenario, and globulins would be high there. So whenever you find a high globulin, then you have to sort out whether it's clonal or not. If it's monoclonal, you have got some disorders like myeloma, Waldenstrom's, all those. If it's polyclonal, you have to think about reactive processes. Why PCR?
Is CML BCR ABL translocation to find out.
Okay, so PCR or fish? Fish, you will get the diagnosis quickly.
Yes.
So in fish, what are you seeing in fish and what in PCR? In fish, you are seeing for the specific translocation.
Okay, sir.
Okay, where karyotyping is all the chromosomes are arranged in order. On structural abnormalities, either there is an additional chromosome or is there is a loss, either in the long arm or a short arm. Those things you are going to see on a karyotype. Fish is only a specific abnormality. What you're suspecting, you're adding probes for that, and you're going to see whether it's there or not. Okay, PCR is like it picks up the product of that translocation. For example, PCR is in one chromosome, ABL on other. The two different genes on two different chromosomes, they get translocated, they fuse, they form a transcript, they fuse, and then that fusion product is what you're going to see in the PCR.
Okay.
Okay, so that is important there. And bone marrow examination, what all will you do? If you're collecting samples,
yes, sir.
And marrow, what are the samples you would collect?
Fine.
Any marrow examination, what all you will collect?
Bone marrow biopsy.
So first is aspirate.
Okay.
So just take only the first 0.5 ml of aspirate, not more than that. If you collect more than that, you will get more amount of diluted blood. Peripheral blood will gush into the syringe. So that is important. Then adequate biopsy.
Okay.
So at least 1.5 centimeter, where your microscopy will show at least 10 marrow spaces. That is important. You should have cortex as well as medulla. The medullary part is more important to see the pathological changes there.
Okay.
And after that, once you collect an aspirate, before the biopsy, you have to collect 2 additional samples in heparin tube and EDTA tube.
Okay.
Heparin goes for cytogenetics and fish.
Okay.
The EDTA goes for immunophenotyping if it's needed. So you collect samples. Once you aspirate for the first 0.5 ml, immediately your attendant or the other person or a staff should collect 2 ml each into those 2 tubes.
Okay, sir.
Before removing the needle. You collect those and see the morphology, and then you can process or not. Whether if it's needed, you can process, otherwise you can discard. Then you get then you drill and get a proper bone marrow biopsy, put it in the formalin, and especially on all PUOs, additionally you have to collect a bone marrow culture.
Okay.
If you are not finding an answer, the patient is running fever for 3 weeks or more, you don't have an answer, you collect samples. And in case, if you want to rule out tuberculosis pathology, or a fungal pathology, when you get a biopsy, a small portion goes for TB PCR.
Okay, sir.
TB PCR, where will you put in the specimen goes into what container? The biopsy goes into formalin
Okay, sir.
for histopathology. If you want to do a TB PCR, these things are important when you do a marrow because it's a precious procedure and you
Okay.
can't subject the patient again for examination.
Okay.
Most of the times, the patient may not agree for a second marrow examination. So that's why I'm just going through all this.
Okay.
You have collected aspirate and 2 additional samples for either cytogenetics of fish and immunophenotyping. You have
Okay.
taken a biopsy. Before putting the biopsy into the formalin, a small portion, if you are going to do a TB PCR, put in some sterile saline, and
Okay,
on that they can run the TB PCR once they extract the nucleic acid material there.
Okay.
The formalin tissue goes for histopathological examination. And
Okay.
if you want to collect a culture at the time of aspirate, it's after the aspirate. Once you have collected those 2 samples for flow and cytogenetics in EDTA and heparin respectively, collect maybe 10 ml and put it in the backtech container. So that will be the order. Aspirate first 0.5 ml, then 2 ml each for immunophenotyping and cytogenetics.
Okay.
Then maybe 10 ml for bone marrow culture
Okay.
before you stop, and then only take the biopsy. And
Okay,
biopsy, a small portion, maybe you can subject for TB PCR examination if you want. That should be in the saline. Label the container properly as saline.
Okay.
And the other larger portion for histopathology into the formalin tissue.
Okay.
In the same day, the pathologist can see the slides and decide whether to process cytogenetics. Cytogenetics would be helpful for patients with CML and all, 922. The fish you can get in 24 to 48 hours time. Some labs even do rapid fish. And on the same day, you might get if they are processing it faster, on the same day, you will get 922 translocation and all, or the PCR. So rarely you would need mutation testing. Nowadays, we have got the NGS. Specifically, you can ask for specific mutations. Like, for example, patients with myelofibrosis, you can ask for JAK2, CALR, MPL. Or patients with Waldenstrom's, you can ask for MVD88. All those are available. If you're not sure if it's a myeloproliferative neoplasm, you don't know where to fit in. Sometimes it could be a myelofibrosis, or it could be an essential thrombocytosis, or a polycythemia rubra vera, even with a large spleen, still it's possible. Those scenarios, you ask for a myeloid NGS panel. NGS next generation sequencing, where you do all the mutations rather than asking JAK2, because myelofibrosis, sometimes JAK2 might be there, sometimes it's MPL, sometimes it's CALR. You don't know what it is. Just JAK2 negativity does not rule it out. Sometimes you can have a triple negative myelofibrosis. All the mutations may not be there, and still your morphology would fit in for myelofibrosis. Other important thing you have to remember, whenever you encounter a patient with a large spleen and a normal hemoglobin.
Okay.
So you're seeing a patient with a large spleen and hemoglobin is normal. Massive spleen, 18 centimeter spleen, but your hemoglobin is 14 grams. And your platelets are 3.5 lakhs. White cells of maybe 12,000. What will you think? What happens to the CBC when the spleen enlarges? Especially over a period of time.
Hypersplenism features.
Yeah, so that's nice. So that's what happens. So when the spleen enlarges, it goes crazy. It works more because all the macrophages hypertrophy. So the volume within the spleen is large. So obviously the blood has to circulate within the splenic tissue for a longer time. So the more and more blood cells, peripheral blood cells are exposed to macrophages, they are removed more. So that's what results in hypersplenism. So despite hypersplenism, if the patient has a normal hemoglobin, especially with a large spleen is large, but you're finding a patient with hemoglobin of 14 grams. So that's more likely a polycythemia rubra vera. Because once the spleen enlarges, hemoglobin will drop.
Yes.
a massive spleen with a normal despite a massive spleen, hemoglobin is normal.
Okay.
So then that is likely a possibility of myeloproliferative neoplasm underlying there, especially polycythemia rubra vera.
Okay.
The same thing applies even in with that's one of the reason in CML you don't see thrombocytopenia often. Either the platelet is normal or high, usually.
Okay.
That's you have to remember. And other soft pointers for you, apart from splenomegaly, would be basophilia. Most of the myeloproliferative neoplasms will have mild basophilia because normally basophil is 1% or less. On a
Okay.
differential count, if we find 2 or 3% basophils, it's significant, especially with leukocytosis.
Okay.
Anything more than 1% basophil becomes significant. So those are soft pointers for you, which would favor more towards myeloproliferative neoplasm. So you have to put things together. Examination, long-standing history, no acute symptoms, and you find a large spleen with absence of organomegaly. Your smear examination is very important. LDH will be raised, and anemia may be there. Polycythemia, you may not find anemia, and based on your smear examination and marrow findings, you have to go further.
Okay.
Sir, anything more?
Nothing, sir. Nothing, sir.
Okay.
I think Dr. Girish might have learned a lot of points very important from the exam point of view. You might have learned that you're not supposed to be very much biased towards your history take.
Okay.
Yeah? Hello?
Sir?
Girish, are you there?
Yes, sir, I'm there.
Yeah, from this presentation, what did you learn? You're not supposed to be very much biased towards the history. Already, if you're aware about the diagnosis, don't create your story of the patients, especially historical aspects plus the examination finding towards the diagnosis. Try to be more open-minded and start asking the questions. It's always better to start your discussion with the patient open-ended questions instead of going for closed-end questions.
Okay, sir.
And we should be more, proactive in the answering capacity. We're very much hesitant, and the words are, we have to extract the words or the answer from you. It is not the way expected from the postgraduate level of learning.
Okay, sir.
Probably all this platform is meant for this type of committing mistake and try to correct your mistakes here so that you don't make the mistakes in the real examination.
Okay, sir.
And a lot of points Dr. Kishwant as well as Dr. Raja Magendran as well as Dr. Subbaya taught you regarding the finer aspects of gastroenterological examination as well as the hematological point of view.
Okay.
Yeah, it's more proactive and just more interactive and clear and common composed mind. It's very important.
Okay, sir.
Yeah. If anything else to add, Dr. Raja Magendran, Dr. Kishwant, and Dr. Subbaya?
No, sir. No, sir. We have Thank you.
I think wonderful discussion and a lot of points postgraduate might have learned.
Yes.
Really thank all the faculties, Dr. Raja Magendran, Dr. Kishwant, and Dr. Subbaya for this wonderful discussion. Really appreciate Dr. Girish. Might have learned a lot of points as well as the other postgraduates also. Really thank the Department of Medicine and Gastroenterology and hematologist Dr. Subbaya from Kaveri Hospital for joining us today. And thank you and good night to all of you. Thank you.
Thank you. Good night.
Thank you, sir. Thank you. Good night, sir.
Thank you, sir.